Chest tube maintenance and troubleshooting. By the end of this presentation, you will be able to identify the proper chest tube insertion site for the treatment of a pneumothorax or hemothorax. You will be able to demonstrate the proper setup for a dry suction water-sealed chest drainage system and Verbalize hospital policy related to chest tube care. You will be able to assess the chest tube insertion site and dry suction water-sealed chest drainage system for conditions that might result in a loss of chest tube function, and you will be able to formulate a plan to restore the negative pressure to the chest tube once the problem has been identified. A chest tube is a semi-flexible cannula that is inserted into the potential space between the parietal and the visceral pleura between the lung and the chest wall. Any circumstance resulting in a collection of air, fluid, or other substances into the pleural space will result in a loss of the negative pressure that's required to keep the lung from collapse. Placing a chest tube into this thin, double-layered membrane allows for the removal of air or fluid, thus restoring negative pressure, resulting in reinflation of the affected lung. A chest tube may be placed as treatment for a pneumothorax, hemothorax, or empyema. A pneumothorax is caused by the collection of air in the pleural space. Air rises, so you would expect to see this chest tube placed in the second intercostal space along the midclavicular line or the fourth intercostal space along the anterior axillary line. A hemothorax is an abnormal collection of blood or fluid within the pleural space. Fluid is heavier, therefore you would expect to see a chest tube placed for the treatment of a hemothorax located in the sixth or seventh lateral intercostal space mid-axillary line. An empyema is the collection of pus caused by an infection that spreads from the lung and tends to collect in loculated regions within the pleural space. On the table next to you is an Atrium Oasis dry suction water-sealed chest drainage system. Pick that up and let's see if we can identify the components of the drainage system. The components are listed on the screen in front of you. Begin by finding the suction port, which is located at the very top of the atrium on the left-hand side. On the front left of your atrium, you'll find the dry suction regulator. The dial to change your suction regulator is located on the edge of that left side. Below the suction regulator is your suction monitor bellows. The bottom left of your atrium is where you'll find your air leak monitor and your patient pressure float ball. The underneath side of your atrium contains the swing-out floor stand. The right side of your atrium consists of the collection chambers for the fluid that's drained from your patient. The corrugated tube at the top right of your atrium is the inline connector for the chest tube, and located on that is your needleless access port. Let's go over the steps for setting up a chest tube. Begin by opening the sterile chest tube package. Next, add 45 ml of sterile water to the suction port located at the top of the drain. The air leak monitor chamber must be filled with the sterile water to the 2 centimeter line. Once filled, water becomes tinted blue for improved visibility of air leaks and convenient monitoring of patient pressures. The Atrium Oasis system does provide you with the 45 ml of sterile water that you will need. You can find it in a squeeze container located on the back of the drainage system. Next, connect the patient's chest tube to the inline connector. If the physician has ordered suction, connect the suction port to the wall suction regulator using a 12-foot extension tubing. The wall-mounted suction regulator must be set on continuous suction with needle placement at -80. Set the suction amount by turning the dry seal suction dial, which is located on the left edge of the collection container to the amount of suction that's ordered by the physician. Confirm adequate suction operation by observing the suction monitor bellows. The orange bellows must extend to or beyond the triangular calibration mark. If the bellows has expanded but is less than the triangular marking, the wall-mounted suction regulator must be increased. Position the chest tubing so that it's free from compression, kinks, or dependent loops. Tube blockage and/or fluid accumulation in the loops will decrease the function of the chest tube. Obtain a portable chest X-ray to confirm chest tube placement directly after insertion. You should see the patient pressure float ball in the water seal chamber gently fluctuate up and down with inspiration and expiration. This is termed titling and indicates increased intrathoracic pressure. As a nurse, you should observe for titling several times throughout your shift. A lack of titling may require troubleshooting. Causes include kinks in the tubing, tube compression, dependent loops, wall suction that is not operating properly, or clot formation within the chest tube. If a clot has formed, the chest tube may be milked gently by manually squeezing and releasing the chest tube between fingers. Stripping the entire length of the tube is contraindicated as it results in transient high negative pressure in the pleural space and lung entrapment. Do not perform stripping of your chest tube without a physician's order. As fluid or air are removed from the pleural space, you will see a decrease in titling. Titling will stop when the lung has fully re-expanded and is an indicator that the tube should soon be removed. Chest tubes placed for the treatment of a hemothorax or empyema should collect fluid in the collection chambers. Drainage usually declines progressively after the first 24 hours. If this fails to occur, notify your physician. Note and document the color and amount of chest tube drainage hourly if necessary. Once the patient is having minimal drainage, it may be appropriate to record the level of drainage every 8 hours. Write the date and time output is measured directly onto the graduated markings of the collection chamber. Document the amount of output measured in Cerner. Continuous bubbling in the air leak monitor chamber may indicate an air leak. Keep in mind that bubbling would be expected when first placing a chest tube in a patient with a pneumothorax. But as we continue to pull air out of that pleural space, we would eventually expect a cessation of the bubbling within that chamber. A patient air leak is confirmed when air bubbles are observed going from right to left in the air leak monitor chamber. Using the graduated air leak monitor, air bubbles create an easy-to-follow air leak pattern for monitoring patient air leak trends, from 1 being a low leak to 5 being high. For patient safety, ensure chest tube clamps and sterile occlusive dressing supplies are readily available at all times. Taping these supplies to the wall above the head of the bed allows for easy access in case of medical emergency. Frequently monitor your patient's vital signs, oxygen saturation, and respiratory status. Auscultation and documentation of lung sounds is required every shift, but is recommended every 4 hours or more for patients with a chest tube. Palpate around the chest tube site above your dressing, feeling for subcutaneous emphysema or crepitus every 4 hours. If subcutaneous emphysema is identified, mark the perimeter with a Sharpie and document your findings in Cerner. Be sure to troubleshoot the cause. One such cause is tube dislodgement. If identified, notify the physician immediately. Leakage around the chest tube insertion site can also cause subcutaneous emphysema. If this is identified as a cause, apply a new Vaseline gauze dressing around the insertion site. Chest tube insertion sites must be covered with an occlusive dressing. Observe the chest tube dressing every 4 hours, looking for excessive or abnormal drainage. Chest tube dressings are to be changed every 48 hours and PRN. To begin, remove the old dressing. Wash the skin around the chest tube insertion site with mild soap and water. Apply a new Vaseline gauze dressing to the chest tube directly at the site of insertion. Cover the chest tube insertion site with drain sponges and 4x4 gauze. Cover the dressing with occlusive tape. Ensure that the chest tube is taped to the skin to prevent accidental dislodgement. Make sure all connection points in the chest drainage system are banded or taped. Accidental disconnection or loose connections may lead to the formation of a pneumothorax. Never clamp a chest tube for greater than 1 minute without a physician order. You may disconnect the suction from a chest tube for transport without a physician order. Keep the collection container on even ground and below the level of insertion at all times. Encourage your patient to turn, cough, deep breathe, and reposition every 2 hours. Continually monitor your patient's level of comfort and medicate for pain as needed. Should the physician request a specimen collection, this can be done through the needleless access port located on the corrugated inline connector. Notify your physician immediately for any changes in your patient's status. You will need to change the dry suction water seal chest drainage system when the collection chamber is full. The locking inline patient tube connector provides a convenient system for this replacement. You will need to begin by preparing a new dry suction water seal chest drainage system following the steps previously described in this presentation. When your new collection container is prepared and ready, clamp the inline connection tubing using the slide clamp provided on the inline connector. Disconnect the inline connection tubing from the old dry suction water sealed drain system and attach the new box. Once your new box is connected, unclamp the inline connection tubing. The chest tube should not be clamped for more than 1 minute. You're now able to identify the proper insertion sites for the treatment of a pneumothorax and a hemothorax. You're able to demonstrate proper setup of a dry suction water seal chest drainage system and verbalize hospital policy related to the care of a patient with a chest tube. You're able to assess the chest tube insertion site and dry suction water seal chest drainage system for conditions that might result in the loss of chest tube function, and you're able to formulate a plan to restore the negative pressure to the chest tube once a problem has been identified. For further information, please see the references listed below. Thank you.